This is an extremely high-yield family medicine review to increase your score on exam day. So let's begin. Post-op urinary retention. Urinary retention is a common post-op complication. Factors associated with this include patient factors such as increasing age and male sex, type of surgery, hernia repair, joint arthroplasty, or anorectal operations. You also have to consider anesthetic factors such as prolonged anesthetic duration, excessive fluid administration, and use of medications that impair bladder emptying, such as opioids and anticholinergics. These patients typically have suprapubic fullness. Urethral injury. Signs of a urethral injury include blood at the urethral meatus, hematuria, and difficulty voiding. What imaging modality is used to diagnose urethral injury? Retrograde urethrogram. Extravasation of contrast from the urethra is diagnostic of urethral injury. Are most cases of posterior urethral injury treated with immediate or delayed surgical repair? And the answer is delayed surgical repair. So basically for these patients, you want to do a temporary urinary diversion by a suprapubic catheter, followed by delayed repair. Anterior urethral injuries, for example, from straddle injuries or penile fractures, are typically repaired urgently, like within 24 hours. Foley catheters are not recommended for patients with suspected urethral injury. Ureter injury. This is usually due to gynecological procedures such as hysterectomy, and these patients can present with ureter obstruction, hydronephrosis, and non-radiating back pain and costovertebral angle tenderness. If only one ureter is involved, the creatinine can be normal. To diagnose an injury to the ureter, you can do a renal ultrasound. Unilateral urethral laceration during hysterectomy may present with intra-abdominal urine collection and abdominal distension. It might overflow through the vaginal sutures as vaginal discharge. Bladder injury. Rupture of the dome of the bladder can cause urine to leak into the peritoneal cavity and can lead to chemical peritonitis. Irritation of peritoneal lining of the right or left hemidiaphragm may cause referred pain to the shoulder or the Kerr sign. Retrograde cystography, in which the bladder is passively filled with water-soluble contrast and then imaged, can confirm the diagnosis. Kidney injury. Evaluation of kidney injury in blunt genitourinary trauma should include urinalysis and contrast-enhanced CT of the abdomen or pelvis in hemodynamically stable patients with evidence of macroscopic hematuria. A retrograde cystourethrogram may be warranted if patients have gross hematuria, difficulty urinating, blood at the meatus, or suprapubic pain. Benign proteinuria. What is the next step in management for a child that is found to have isolated proteinuria on urine dipstick? Repeat dipstick testing on 2 subsequent occasions. If subsequent tests are negative, the diagnosis is transient proteinuria. If subsequent tests reveal continued proteinuria, further workup is warranted. UTI. What is the first step of diagnosis of a UTI in infants in diapers? Straight catheterization to obtain sterile specimen sample for urinalysis and urine culture. Clean catch specimens are unreliable in diapered patients due to the high likelihood of contamination with stool or skin flora. What is the next step in management for a 12-month-old girl with a confirmed E. coli UTI that is resolving after initiation of antibiotics? Renal and bladder ultrasound. Using antibiotics such as ciprofloxacin is reserved for treatment of UTIs caused by Pseudomonas, which typically occur in patients with an indwelling catheter. Vesicoureteral reflux. This condition causes recurrent UTIs in neonates and children. Diagnosis requires a urinalysis, urine culture, and a contrast voiding cystourethrogram is a test of choice for definitive diagnosis. This is indicated in patients with greater than 2 episodes of febrile UTIs, or they have a renal anomaly detected on ultrasound. Findings of this condition include retrograde reflux of contrast into ureters during micturition. A cystourethrogram consists of instilling contrast into the bladder through a Foley, and images are obtained via fluoroscopy while the child is voiding. Multiple myeloma. What screening test should be useful for evaluating an elderly patient with chronic arm pain, anemia, and back pain? A serum or urine protein electrophoresis. This is the best initial test. Or you can do a free light chain analysis. A patient is diagnosed with multiple myeloma. What imaging should be performed? Full body X-ray or skeletal survey looking for lytic bone lesions or pathological fractures. Bone scans are not useful in the diagnosis of multiple myeloma as they detect only osteoblastic activity. Can you tell me which conditions can cause osteoblastic lesions? Leave them in the comment section below. Also, if you're liking this content so far, please be sure to power up that like button, hit subscribe, and that notification bell so that you never miss another video like this. Hodgkin's lymphoma. What is the likely diagnosis in a patient with a past medical history of Hodgkin lymphoma, status post-chemotherapy or radiation, who presents with cough, dyspnea, and chest pain? Secondary malignancy. There is an increased incidence for developing a second cancer in Hodgkin lymphoma patients compared to the general population. Most common sites are the lung, breast, thyroid, bone, and GI system. Tumor lysis syndrome. Patients with this condition have electrolyte abnormalities such as hyperphosphatemia, hyperkalemia, and hyperuricemia. To treat them, you want to give IV fluids, also uric acid reducing drugs such as resveratrol or allopurinol, and of course you need to treat the electrolyte abnormalities. Spontaneous tumor lysis syndrome can occur in patients who have hematologic malignancies with high tumor burden or rapid replication rate. It presents with acute kidney injury due to tubular obstruction. Uric acid and calcium phosphate stones can cause kidney injury. Nocturnal enuresis. The first step in evaluation of all patients with nocturnal enuresis, both primary and secondary, is a urinalysis. What is the likely diagnosis in a child with a family history of anemia that presents with Coombs negative hemolytic anemia, jaundice, and an enlarged spleen? Hereditary spherocytosis. What is the likely diagnosis in a child that presents with scattered petechiae with isolated thrombocytopenia and enlarged platelets following a viral infection? Immune thrombocytopenia. This most commonly occurs in children between the ages of 2 to 5 years old following a viral infection. In children with ITP, skin manifestations only require observation regardless of platelet count, as ICP is generally self-limiting. To treat, you can give IVIG or corticosteroids. What two viruses should be tested for in an asymptomatic patient with idiopathic thrombocytopenic purpura? HIV and hepatitis C. Platelet transfusions are reserved for life-threatening hemorrhage in patients with ITP. That's another high yield point to note. What is the likely underlying cause of anemia in a patient with a history of gastrectomy that presents with a shiny tongue, pale palmar creases, and laboratory evidence of hemolysis? Labs show indirect hyperbilirubinemia and elevated LDH. Vitamin B12 deficiency. These patients experience this deficiency due to loss of intrinsic factor. High numbers of immature megaloblasts in the bone marrow results in increased intramedullary hemolysis, thus causing indirect hyperbilirubinemia and elevated LDH. TTP. Fever, anemia, renal failure, thrombocytopenia, and neurologic manifestations. So if you see any of those symptoms, well, not any of them, all of them, or most of them, you want to consider TTP. This is a life-threatening condition and must be treated emergently with plasma exchange. Plasma exchange removes the patient's plasma and replaces it with donor plasma. This replenishes ADAMS 13 and removes the autoantibodies. Without emergent plasma exchange, the mortality rate is approximately 90%. It's very important that you identify this emergent condition and treat it as quickly as possible. What is the recommended treatment for symptomatic neonates with polycythemia? Partial exchange transfusion. This is where blood is removed in exchange for normal saline to normalize the hematocrit. Asymptomatic infants may be managed with rehydration. What is the recommended pharmacologic treatment for patients with cancer-related anorexia or cachexia syndrome? Progesterone analogs are preferred, or you can use corticosteroids. Synthetic cannabinoids are useful for HIV cachexia, but not as useful for cancer-related anorexia or cachexia syndrome. What is the most common complication of sickle cell trait? Painless hematuria, and this can either be macroscopic or gross. This occurs due to sickling in the renal medulla, and patients can also experience isothenuria, which is an inability to concentrate urine. Patients with sickle cell can also experience isostenuria, which is an inability to concentrate urine. Pseudogout. In this condition, patients will have calcium pyrophosphate crystalline deposition within the joint space. This may manifest acutely following trauma, surgery, or extreme exertion. It most commonly affects the knee. To diagnose this condition, you need to do an arthrocentesis. This may show the presence of calcium pyrophosphate crystals and an increased concentration of leukocytes. Doing an arthrocentesis also rules out other conditions such as septic arthritis. Plain film x-rays may show chondrocalcinosis and degenerative joint changes. In order to treat these patients, you want to give them NSAIDs and colchicine. So since we just talked about pseudogout, now let's talk about gout. So gout is an inflammatory reaction to the precipitation of monosodium urate crystals within the joint space. It typically affects the first metatarsal phalangeal joint. To treat these patients, you want to give NSAIDs, colchicine, and/or steroids for acute exacerbations. However, for chronic preventive management, this involves the use of xanthine oxidase inhibitors such as allopurinol. It's also important that patients with gout avoid triggering risk factors such as purine-rich meals and heavy alcohol consumption. As you can tell for pseudogout and gout, there are different crystals that accumulate in the joint space. It also affects different joints, and the treatment is also different. So it's very high yield that you know the differences between pseudogout and gout. Ankle sprain. Twisted injuries of the ankle are common and more frequently result from inversion injuries to the lateral ankle. To diagnose an ankle sprain, the most important step in evaluation of ankle injuries is to determine if the patient requires imaging to rule out a clinically significant fracture by applying the Ottawa ankle rules. So, what are these Ottawa ankle rules? Well, first, you have an inability to bear weight immediately after injury and in the emergency department, or bone tenderness at the posterior edge of the tibia or fibula or tip of the medial or lateral malleolus. 3. Bone tenderness at the navicular or proximal base of the fifth metatarsal. If any one of these are present in the patient, then you want to go ahead and get some imaging done of the ankle. However, if it is negative, then you can use a soft protective brace and early range of motion exercises. Lateral ankle sprains of the anterior talofibular ligament are the most common encountered ankle sprains. This occurs when a plantar flex foot is inverted. Most patients with ankle sprains do not benefit from X-ray imaging. Ultrasound may be useful for assessing the integrity of a ligament. Most patients with ankle sprains improve with conservative management, including rest, application of ice, compression, and elevation of the affected joint. Polymyalgia rheumatica. Patients with this condition experience stiffness and aching of the proximal muscles and joints of the neck, shoulders, torso, and hips, especially in the morning. Systemic inflammation, such as fever, chills, malaise, fatigue, increased CRP, and ESR, can also be seen. Increased risk of developing giant cell arteritis. So this is very important. When you're thinking about polymyalgia rheumatica, you have to think about the potential for developing GCA. These conditions often coexist. Patients should undergo a thorough examination to exclude the presence of GCA and be counseled on its symptoms. For example, headache, jaw claudication, temporal tenderness, and amaurosis fugax. To treat polymyalgia rheumatica, you can give oral corticosteroids such as prednisone, which is often required for a prolonged course, usually 1 or 2 years. Okay, now let's do some quick pharmacology review. Amitriptyline is a tricyclic antidepressant that is useful for the treatment of fibromyalgia. Cyclophosphamide is an alkylation agent that is useful for the management of severe cases of a variety of rheumatic conditions, including SLE, RA, and granulomatosis with polyangiitis. It has significant adverse effects, for example, hemorrhagic cystitis and myelosuppression. So basically, I just wanted to highlight two drugs that are used in rheumatologic conditions or chronic pain conditions, and also to highlight some of their adverse effects that can present on your exam as well. Falls in the elderly. Normal aging can lead to decreased muscle strength and balance, which can lead to frequent falls. Physical therapy is often used. Evaluate for other causes, for example, decline in vision, cognitive impairment, medication adverse effects, polypharmacy, arthritis, and orthostatic hypotension, and the list goes on. So, of course, normal aging can lead to falls, but you can't just have an elderly patient come in and just say, oh, it's due to your age and not evaluate further. Look for other possible causes. You also need to evaluate events leading up to the fall. Like, did they have any chest pain, arrhythmias? Did they lose consciousness? Just find out what was going on leading up to the fall. The get up and go test can help the physician risk stratify patients for their likelihood of falls. Carpal tunnel syndrome. In this condition, there is compression of the median nerve. Patients may experience pain, weakness, or paresthesia of the first 3 digits and have positive provocative test maneuvers such as the Tinel or Fallon tests. Mild symptoms are treated with wrist splinting. Wrist splints are typically worn at night but may also be used during the day. Splinting reduces the range of motion of the wrist and limits activities that increase pressure within the carpal tunnel. Patients who have persistent or severe symptoms or muscular weakness may require surgical decompression. Diabetic neuropathy. Patients with this condition often complain of a stocking glove distribution and gradual descent from the feet. To diagnose a diabetic neuropathy, a monofilament is applied with light pressure to 5 separate points on the plantar surface of the foot. Loss of the ability to detect one or more of these pressure points should prompt further evaluation and tighter glycemic control. To treat diabetic neuropathy, gabapentin is first line. Carbamazepine is also another option. If refractory to these drugs, you can use nortriptyline, a tricyclic antidepressant medication. Patients also need to do frequent foot examinations to detect any ulcers, cuts, or fungal growth that may predispose to a diabetic foot infection. Lateral epicondylitis. Patients with this condition experience pain in the lateral elbow with wrist extension. It's very important that you remember that because examiners like to just fit this word around to wrist flexion. So remember, lateral epicondylitis, pain in the lateral elbow with wrist extension. This is commonly seen in tennis elbow. Physical exam reveals tenderness over the lateral epicondyle and over the insertion of the extensor muscles of the wrist. To treat, we can implement activity modification and a compression sleeve or counterforce bracing apparatus. Very high yield. If you're enjoying this content so far, please be sure to power that like button, hit subscribe, and that notification bell so that you never miss another video like this. Osteoarthritis. A major risk factor for this condition is obesity. Patients typically present with joint pain that gets worse throughout the day with this condition. The most commonly affected joints are the first carpal metacarpal joints, as well as the distal interphalangeal. Patients may even have Herpden or Bouchard nodes without active synovitis. Imaging of osteoarthritis may reveal joint space narrowing, subchondral sclerosis, subchondral cysts, and osteophytes. First-line treatment includes acetaminophen, second-line treatment NSAIDs such as naproxen, and third-line treatment is joint replacement surgery. Psoriatic arthritis. This condition is typically asymmetric and often presents with dactylitis and involvement of the distal interphalangeal joints. Erythematous salmon-colored patch with silvery scales on the elbows and knees and joint pain in fingers may all be indicative of psoriatic arthritis. When you do imaging of these joints, you may see a pencil and cup deformity. Preferred treatment is with NSAIDs. Now let's discuss arthritis and hypertension. Naproxen and other NSAIDs are COX enzyme inhibitors, which have a primary role in synthesizing prostaglandins and prostacyclins. NSAID use can precipitate acute kidney injury because of decreased prostaglandin synthesis, which would otherwise promote renal afferent arterial vasodilation. This can cause worsening of hypertension, especially in patients taking ACE inhibitors such as lisinopril. As a result of autoregulation mechanisms, increase in blood pressure to increase renal perfusion. So, if in a clinical scenario you have a patient with arthritis and hypertension, and let's say that their hypertension was previously controlled, but once you started managing or treating their arthritis, their hypertension is no longer controlled or it's just higher than normal. This is something that you need to consider. Look at what hypertensive drugs they're currently taking and what arthritic drugs they're taking, and see if any changes can be made so that both conditions can be managed appropriately. Biceps tendonitis. Patients with this condition have a history of repetitive throwing, pulling, or lifting and usually present with anterior shoulder pain. The biceps tendon consists of one short and one long tendon. Injury to the long tendon is more common than injury to the short head, giving its anatomic location. Physical exam may reveal pain upon palpation of the tendon within the intertubercular groove, located along the anterior humerus. To treat, these patients require adequate rest and gradual reintroduction of activity. Septic arthritis. The next best step in management, of course, is an arthrocentesis. You want to go ahead and treat these patients with a joint washout and antibiotics. If you suspect a gonococcal arthritis, you can give ceftriaxone and doxycycline or azithromycin. The most common cause of septic arthritis is Staph aureus. The most common cause in sickle cell patients is Salmonella. In septic arthritis, patients have fever, reduced range of motion of the affected joint, and refusal to bear weight. Labs may show leukocytosis and increased concentrations of inflammatory markers such as CRP and ESR. When you get back that arthrocentesis results, you can note purulent synovial fluid with more than 50,000 leukocytes. Treat with operative management and antibiotic coverage of empiric pathogens, for example vancomycin and a third-generation cephalosporin. Acute rheumatic fever. Patients with this condition may have migratory polyarthralgia, pancarditis, subcutaneous nodules, erythema marginatum, fever, increased ESR, and short PR intervals following an infection from group A strep, most often pharyngitis. So if a patient had a group A strep infection or pharyngitis, and then they have this Pancreatitis, the subcutaneous nodules. You want to think about acute rheumatic fever. Leg calf perthes disease. This is an idiopathic avascular necrosis of the femoral head that most commonly occurs in younger boys from 4 to 9 years old. They have a slow onset of hip pain, which is worsened with activity and associated with a limp. They typically have no fever or leukocytosis. If you're enjoying this content so far, please be sure to pop the like button, hit subscribe, and that notification bell so that you never ever miss another video like this. Reactive arthritis. Can't see, can't pee, can't climb a tree. That's what we use to remember reactive arthritis. This is typically associated with HLA-B27, and the classic bug is chlamydia. We treat these patients with steroids, and we only give antibiotics if there is an ongoing infection. Rheumatoid arthritis. This is an autoimmune inflammatory arthropathy that results in symmetric involvement of multiple joints, most commonly the MCP and PIP joints of the hands, demonstrating articular erosions and progressive joint space narrowing. Ulnar deviation of the fingers and boutonniere and swannet deformities commonly occur. So let's say that you have a woman being treated for rheumatoid arthritis. It's well controlled and she wants to become pregnant. What therapy needs to be stopped in pregnancy? Methotrexate. This inhibits dihydrofolate reductase and can cause neural tube defects. Hemochromatosis. So let's say that you have a 6 to 5-year-old male that has erectile dysfunction and skin hyperpigmentation. You also note new onset diabetes, pseudogout, and arthritis in the shoulders, elbows, and ankles. Well, you want to consider hemochromatosis. The pathophysiology of this condition is that there is iron deposition in various organs. And this iron that is deposited in various organs can undergo oxidation, which causes destruction. We treat with phlebotomy. This is also the treatment for polycythemia and porphyrocutinea tarda. It has an autosomal dominant inheritance. Patients with hemochromatosis are found to have mutations in the HFE gene. If patients have injury or damage to the ulnar nerve, you may note weakness and muscle atrophy of the medial aspects of the hand. The supraspinatus tendon is the most common location of rotator cuff injury. Injury to the supraspinatus tendon may occur from degeneration, impingement, or trauma and can be evaluated through AB or abduction of the shoulder against resistance. Knowing the rotator cuff muscles is very high yield. I have a video that goes through that and I'll be sure to list that in the description below. Osteosarcoma. Patients have chronic pain, bony swelling, and a history of malignancy in childhood. So this would raise suspicion of osteosarcoma. It's the most common type of primary bone cancer. It typically occurs in long bones, frequently above the knee in the distal femur or below the knee in the proximal tibia. The metaphysis is often affected. Causes include familial cases, especially involving the retinoblastoma or p53 tumor suppressor genes, bony dysplasia such as osteitis deformans or Paget's disease, and fibrous dysplasia and exposure to radiation. To diagnose this condition, you need to do bone biopsy, and it's also supported by radiographic findings such as the Codman's triangle. Osteoporosis. But in this condition, the DEXA scan reveals bone density less than 2.5 standard deviations compared to a young, normal population. Risk factors include low BMI, age, smoking, chronic inflammatory disease, corticosteroid use, and estrogen depleting conditions in women. But the top risk factor is low BMI. So if you see a clinical scenario and you know for sure that this patient has osteoporosis, and they ask you what is the greatest risk factor for developing this condition, most likely the answer will be a low BMI. Osteoporosis increases the risk for fractures, most commonly involving the hip, vertebrae, and distal radius. Slipped capital femoral epiphysis, or SCFE, most commonly occurs in overweight children between the ages of 10 and 15 years. It results in a displacement of the femoral epiphysis relative to the femoral neck caused by a fracture of the growth plate. Another condition to know is toxic transient synovitis or transient synovitis. This is an inflammatory arthropathy that presents with pain in a joint, often the hip, frequently following a viral infection in a child. So, a little more on osteoporosis. We can prevent this condition by giving calcium and vitamin D supplementation, reduction of active osteoporotic risk factors, and weight-bearing exercises. So remember, risk factors for osteoporosis that you can actually change or that are modifiable includes smoking. However, you can't really do anything about, the patient's age. And another major risk factor is low BMI. So we can probably implement a diet or different factors that could correct that in a healthy manner. Bisphosphonates such as alendronate inhibits osteoclast activity. They are utilized once an individual is diagnosed with osteoporosis to reduce further loss of bone mineral density. So, dactylitis. This presents at age 6 months to 4 years with an acute onset of pain and symmetric swelling of the hands and feet. If you see this, especially in African American patients, you want to consider that this may be due to sickle cell disease. Some additional points to note is with this question, what is the most common cause of sepsis in patients with sickle cell disease? Strep pneumoniae. Broad spectrum empiric antibiotics such as ceftriaxone should be given to patients with sickle cell disease presenting with sepsis. What is the likely diagnosis in an adolescent with a history of hemophilia A that presents with gradually worsening pain and limited motion of his knee? Hemophilic arthropathy. Patients can have recurrent bleeding, which leads to hemosiderin or iron deposition, leading to synovitis and fibrosis within the joint. The risk is significantly reduced with prophylactic factor concentrates. Some bonus points on hemophilia is that inhibitor should be suspected when a patient with hemophilia A on factor replacement therapy develops increased bleeding frequency or has hemorrhage refractory to treatment. Treatment of an acute bleed in a patient with inhibitor development often involves bypassing products, example, activated prothrombin complex concentrates. Peripheral artery disease. PAD of the upper extremities is characterized by pain with exertion and can cause gangrene and ulceration. It's more common in patients who've had lower extremity occlusive disease. A blood pressure differential of 15 between arms suggests stenosis and warrants further testing. Initial testing in symptomatic patients includes arterial duplex ultrasound of the upper extremities. CT angiography and MR may be appropriate to clarify the diagnosis or plan intervention. Guideline-directed therapy for PAD includes low-dose aspirin, moderate to high-intensity statin therapy, an ACE inhibitor, or ARB, structured exercise program, smoking cessation. Myalgia paresthetica. This is a common cause of anterolateral hip pain and dysesthesia. It's caused by a compression of the lateral femoral cutaneous nerve as it courses under the inguinal ligament into the subcutaneous tissue of the thigh. Tapping over this area during the exam can reproduce pain or symptoms. Obesity is a common cause of this condition. Diabetes is associated with a 7-fold higher incidence over the general population. The anterolateral thigh would represent the L3 to L4 dermatome. So this is very high yield. Remember, myalgia paresthetica, it affects the anterior lateral side. It can cause anterior lateral hip pain, and it's due to a compression of the lateral femoral cutaneous nerve. A common cause is obesity, and there's a higher incidence in patients with diabetes mellitus. Also remember that dermatome. That's a nice way that examiners like to bring back some anatomy that you should know. Cauda equina syndrome presents with saddle anesthesia and generally marked neurologic disability. Diabetic neuropathy is a peripheral neuropathy initially affecting distal structures such as the toes and feet. Femoral neuropathy would affect sensation in the anterior medial thigh and medial lower leg with weakness in the quadriceps muscle group. If a patient has a positive straight leg raising test and back pain, this is evidence of an S1 issue. Thyroid nodules. The first step in the evaluation of a palpable thyroid nodule is to obtain a TSH level and perform thyroid ultrasound. If a patient has a low TSH, a radionuclide thyroid uptake scan is the appropriate next step to assess for a hyperfunctioning nodule. If the TSH level is normal or high, next steps are determined by the size and characteristics of the thyroid nodule on ultrasound. Fine needle aspiration or FNA may be indicated depending on the size and nodule characteristics. Molecular testing of FNA specimens is useful in order to guide management of thyroid nodules with indeterminate cytology. The 2016 CHEST guidelines strongly support the recommendation to do 3 months of anticoagulation after a first episode of a provoked proximal DVT of the leg. So let's talk about decorative veins. Patients with this condition have a history of an atraumatic onset of radial-sided wrist pain. It is a common overuse injury involving the tendons of the first dorsal compartment, specifically the AB or abductor pollicis longus and extensor pollicis brevis. It's most common in women 30 to 50 years of age and often occurs in new mothers who frequently pick up a child. Pain localizes to the radial styloid, and this can be reproduced by the Finkelstein's test, which involves placing the thumb inside a closed fist followed by ulnar deviation of the wrist. Focal tenderness in the anatomic snuff box would suggest injury to the scaphoid, which is in the differential diagnosis for radial-sided wrist pain, although it usually occurs through direct trauma as a fall onto an outstretched hand. Colon cancer. The recommended interval for colon cancer screening with multi-target stool DNA testing is 3 years at minimum, with the USPTF recommending an interval of 1 to 3 years. If the screening is positive, proceeding with a colonoscopy is recommended. Fecal immunochemical testing, or FIT, has an annual screening interval if the test is negative. A colonoscopy is recommended if the FIT is positive. Colonoscopy for patients without risk factors should be performed every 10 years or sooner if indicated by pathology results or risk factors. COPD. Initial treatment is with smoking cessation, long-acting agonist or LABA, or a long-acting muscarinic antagonist or LAMA. If symptoms persist with either of those inhaled medications, then combination therapy should be initiated. An inhaled corticosteroid can be added to the LABA-LAMA regimen for triple therapy if symptoms continue. Long-term use of an ICS or inhaled corticosteroid as monotherapy is not recommended due to a slight increase in the incidence of pneumonia. So as you can see, the initial treatment for COPD is similar to like a step-up treatment as for asthma patients. So first, smoking cessation, then a LABA or LAMA. If this doesn't work, use the LABA and LAMA together. If those two together don't work, then we need triple therapy. Add an inhaled corticosteroid to that, but never use the inhaled corticosteroids by itself. When a COPD exacerbation is caused by infectious agent, it may be bacterial or viral. GOLD guidelines support the use of antibiotics in patients with an acute COPD exacerbation with the three cardinal symptoms of increased dyspnea, increased sputum volume, increased sputum purulence, and in patients who require invasive or non-invasive mechanical ventilation. So increased dyspnea, increased sputum volume, increased sputum purulence, and mechanical ventilation. In those scenarios, you can use antibiotics to treat the COPD exacerbation. If a patient has a fever and hypoxemia, even though this is often seen in the setting of COPD exacerbations, they do not provide as strong an indication for treatment with antibiotics. Diffuse wheezing. Now, this is a hallmark examination finding that is present in most COPD exacerbations, regardless of the underlying cause. Leukocytosis is a relatively nonspecific marker for acute inflammation and may be seen with either viral or bacterial etiologies. So basically, this slide is bringing out the facts that if you see a patient that has diffuse wheezing, they're hypoxic or have fever and leukocytosis, those aren't the cardinal symptoms for using antibiotics. It's the increased dyspnea, increased sputum volume, increased sputum purulence, and in patients who require invasive or non-invasive mechanical ventilation. Eating disorders. A DEXA scan is recommended to assess for low bone mineral density in patients with suspected or diagnosed eating disorders. Other appropriate screenings include orthostatic vital signs, a basic metabolic panel, CBC, magnesium, phosphorus, prealbumin, and amylase levels, thyroid testing, and an EKG. Hormonal contraception. Obtaining a thorough medical history is standard practice, but the Choosing Wisely campaign recommends against requiring a pelvic or other physical exam prior to prescribing oral contraceptives. So if a question asks you, hey, a patient comes in, she wants to start some contraception, Will she need to do like a pelvic exam before? The answer is no. She doesn't need to do a pelvic exam before you prescribe oral contraceptives. It is unnecessary to wait to begin hormonal contraception until after the next menses, as inadvertent exposure to oral contraception will not harm an early pregnancy. Prescribing a 1-year supply of hormonal contraceptives improves adherence and lowers costs. There is a broad consensus that sexually transmitted infection screening and pap smears should not be required to prescribe contraception. Orthostatic hypotension. So to treat this condition, you need to identify and address the underlying cause or causes when possible. This may include correcting a reversible medical condition or discontinuing an offending medication. Can you think of any drugs that can cause orthostatic hypotension? Leave them in the comment section below. Non-pharmacologic measures should be initiated next and typically include increasing fluid and sodium intake, improving physical fitness, wearing compression garments, and avoiding hot and humid environments. When additional treatment is needed, first-line medication options include droxidopa, which acts by increasing peripheral vascular resistance. Off-label use of drugs like atomoxetine may be considered as adjunct therapy, but these medications are not part of the initial management. The alpha antagonist clonidine typically causes a decrease in blood pressure through central action on the sympathetic nervous system. In patients with autonomic dysfunction, however, clonidine can increase venous return without a blood pressure lowering effect and therefore improve orthostatic hypotension, but it should only be considered a supplementary treatment. Phenylephrine may also be considered as a second-line option, but this is not a part of the initial management of orthostatic hypotension. Maturity onset diabetes of the young, or MODY, is a form of diabetes in non-obese young adults under the age of 30 who have preserved pancreatic cell function. Nearly 80% of patients with MODY are misdiagnosed as having type 1 or type 2 diabetes. These patients exhibit no signs of insulin resistance. For example, metabolic syndrome, acanthosis nigricans, skin tags, and androgenic alopecia. They are not obese, have positive C-peptide levels, and have a strong family history of diabetes. MODY does not respond to metformin, but because beta cell function is preserved, the hyperglycemia does respond to sulfonylureas. A balanced diet of appropriate portions and low carbohydrates are also necessary in patients with MODY. Insulin is required only during pregnancy for these patients. Low back pain. If acetaminophen and NSAIDs are ineffective when used alone, the most appropriate next step is a combination of both medications. Acetaminophen and NSAID combinations have been shown to be more effective for acute pain than either agent alone. Other options should be tried before prescribing opioids, such as a hydrocodone acetaminophen combination or oxycodone. You can also implement short-term use of muscle relaxants with NSAIDs as well. Basically, you want to try every combination and everything you can before going to opioids. So opioids should not be your first step when a patient comes in with low back pain. Hepatitis A post-exposure prophylaxis. All unvaccinated household contacts and sexual contacts should receive post-exposure prophylaxis following significant exposure to hepatitis A within the previous 2 weeks. Healthy individuals 12 months to 40 years of age should receive the hepatitis A vaccine as prophylaxis. However, infants less than 12 months of age should receive immune globulin as post-exposure prophylaxis. Individuals older than 40 years of age, as well as immunocompromised patients, should receive both the hepatitis A vaccine and immune globulin. Again, I can't stress enough how high yield this slide is. Knowing post-exposure prophylaxis is extremely important, so definitely commit this slide to memory. Pertussis. Azithromycin is the most appropriate for the management of pertussis. Azithromycin is most effective for treatment and minimizing spread of the disease within 21 days of symptom onset. Macrolides such as erythromycin are also acceptable options. Wound care. The most important aspect of infection prevention in treating a superficial wound is cleaning and irrigation. Studies have shown that irrigation with tap water provides similar outcomes compared to sterile saline. Antiseptic solutions such as hydrogen peroxide are not more effective than tap water and can be caustic to wound tissue and may delay healing. Very, very high yield. Antibiotics should be used for treatment of wound infections. However, non-infected wounds do not routinely require antibiotic prophylaxis unless there is an increased risk of infection. Risk factors for a wound infection include bite wounds, delayed presentation, retained foreign material, insufficient cleaning, puncture or crush wounds, open fractures, significant immunocompromise, and joint, cartilage, or tendon involvement. Patients with 3 or more doses of tetanus toxoid with the most recent vaccination within the past 5 years do not require tetanus booster or tetanus immune globulin for prophylaxis, regardless of the type of wound. Croup. This condition peaks in fall and winter months. Diagnosis is purely clinical and does not require lab studies, viral cultures, or imaging. The treatment of croup includes corticosteroids such as dexamethasone in mild cases and the addition of epinephrine in moderate to severe cases. The inhalation of humidified air does not improve outcomes, nor does nebulized albuterol. MET or MET is the amount of energy used by the body per minute of activity. Light intensity is less than 3 METs and includes activities such as sitting at a desk, light housework, casual walking, and stretching. Moderate intensity is 3 to 5.9 METs and includes brisk walking, water aerobics, and ballroom dancing. Vigorous intensity is 6 METs and is represented by activities such as high-intensity interval training, jogging, and heavy gardening. Pityriasis versicolor. This is a superficial infection caused by yeast in the genus Malassezia, and treatment includes topical selenium sulfide, topical antifungals such as terbinafine, and miconazole are the other first-line options. Oral fluconazole can be used, but oral therapy is usually reserved for when topical treatment is impractical or unsuccessful. Male infertility. A semen analysis is the first step in the evaluation of male infertility. In males with oligozoospermia, especially if the sperm count is less than 10, the American Urological Association recommends an endocrine evaluation with an FSH level and early morning total testosterone levels. The results of that testing can dictate next steps. Oppositional defiant disorder. The DSM-5 criteria for a diagnosis of ODD includes frequently losing one's temper, being easily annoyed, antagonism toward authority figures, deliberately annoying others, placing blame on others, and being spiteful or vindictive. These symptoms must occur for at least 6 months, cause distress or negative impacts, and not occur exclusively with substance use or in the course of a psychotic, depressive, or bipolar disorder. Treatments of common comorbid mental health conditions can be associated with an improvement in ODD. So it is very important to evaluate for ADHD, depression, and anxiety disorders, as well as ODD. Patients with ODD have a high risk of developing other mental health conditions later, and early therapy is recommended. Medication is rarely indicated for ODD and not as monotherapy. Therapy should generally include both child therapy and parent training. Hypertension. The USPTF recommends screening for hypertension with office blood pressure measurements in adults older than 18 years of age. Adults older than 40 and those greater than 18 with risk factors should receive annual hypertension screening. Less frequent screening is recommended for adults 18 to 39 without risk factors. The USPTF recommends abdominal duplex ultrasound for men 65 to 75 years of age who have ever smoked, which is usually defined as 100 cigarettes or more in a lifetime. Influenza vaccine. This vaccine is safe to administer regularly to those who have only had hives after exposure to eggs. If more serious allergic symptoms occur with egg exposure, such as respiratory distress or anaphylaxis, the influenza vaccine should be administered in an inpatient or supervised outpatient setting. Pre-medication with diphenhydramine or prednisone is not recommended.